Welcome to the latest installment of the IDMP seminar series here at the Broad Institute. Thanks for tuning in so faithfully, despite the fact that I'm sure that you're all sick of me and have seen enough of me in the last few weeks. You can also see the lineup for the upcoming meetings that we've scheduled with folks who have been extremely generous with their time in a particularly hectic time for each of them. So today we have the pleasure of having Yonatan Grad join us. He is a assistant professor at the Harvard School of Public Health. And he's also a medical doctor. And I think that Yonatan and I first met each other. We were just reminiscing back when he was an intern at the Brigham and Women's Hospital when he and I were both attending in the medical intensive care unit there. So Yonatan trained as a graduate student with George Church and then more recently with Mark Lipsitch, turning his focus to studying from an epidemiological perspective infectious diseases. And he and I have talked, and I have suggested that he has the unenviable position of trying to predict possible outcomes from infectious events. And based on their predictions, people change behaviors so that inevitably their predictions are wrong. But nevertheless, we're grateful because indeed, it's folks like Yonatan who motivate us to change our behaviors and change the course of outbreaks just such as COVID-19. So with that, I'll turn it over to Yonatan.
Thank you very much, Deb. Just to make sure you can see my screen, is that?
Yes.
Great, perfect. So thank you to Deb for the invitation. I also want to say thank you to Eric Lander for his individual leadership and also the leadership and efforts of the Broad Institute and the many people there who are working very hard to try to address the current pandemic. So the title of this talk, Navigating the COVID-19 Pandemic from Life Raft to Dry Land. This is based on the thinking that I've been doing, and this as well is based on, in case you want to have the short version and not listen to the full hour, you can read this piece in Stat News written by Mark Lipsitch and myself, and I will fully attribute the excellent metaphor of the life raft and dry land to Mark. So you can read this. There's the link down at the bottom. If you want to get the short version. Okay, so jumping in, where are we? As I'm sure everyone is familiar with, we see figures like this all the time when we look at the total confirmed COVID-19 cases, numbers going up in the US. Of course, there are issues with testing where even though we're seeing expanded testing in some places, there are backlogs in others. So we know that the true number of cases is probably much larger than this. Nonetheless, we're seeing exponential growth consistent with the first phase of the epidemic. Similarly in Italy and in Spain, whereas in some countries, particularly in Asia, like China and South Korea, we've seen that they've been able to flatten their curves. And more somberly, we can look at these figures for the confirmed deaths due to COVID-19, with Italy now over 12,000. Again, these are data from yesterday. Spain over 8,000, and the US also climbing rapidly. This figure is one, at least in concept, that I think many people have seen, but the figure itself is drawn from the White House task force presentation a couple of days ago, where Deborah Birx, the leader of that task force, shared it. We see in the large peak in solid color here what would happen in the absence of any kind of intervention. And then we see this smaller peak where should there be mitigation efforts and again, flattening the curve, we could perhaps see a different shape, a different duration, and hopefully many fewer deaths. So the question though is, how does this end? And how do we reach the end of the pandemic if we consider that our mitigation efforts are represent our clambering into this life raft, where is dry land? And there are two possibilities formally. One of them is elimination of the virus, and you might remember that just a couple months ago, the White House was suggesting that perhaps this would all go away by April. I think we can say fairly confidently that is not going to be the case. And it seems unlikely, very unlikely, that this is really a solution we're looking at. So instead, the ending will come with population immunity. This gets to the concept of the basic reproductive number, which is an epidemiological term that I suspect many are now familiar with too. It basically refers to the idea of how contagious a pathogen is. So if you were to take an infectious individual, how many people on average does that person infect? For SARS-CoV-2, we think that number is somewhere around 3. So in that case, the population immunity that would be necessary to end the pandemic is somewhere around 2/3. And that immunity could be achieved either through infection and then recovery, or through a vaccine. So that's really where I think that the dry land is. But then how do we get there? There are a few different scenarios, which I will now step through, as we've been using modeling approaches, as Deb referred to try to understand what the different paths are and what they look like. So the first option is to just stop social distancing and let it go. So this would be like that solid curve that I showed earlier. But of course, we think that is a bad option. You know, we've seen examples from Wuhan, from northern Italy, and you get the sense of just how dramatic and devastating it can be to have the epidemic happen all at once in a location, and the demand that that puts on the healthcare system. Here we can see that you know, the Wuhan shut the city down when they had around 500 confirmed cases in a population of 10 million. They reached per capita demand for ICU equal to fully occupying ICU beds in the US. And this was just for COVID-19. And it took about 4 weeks from the shutdown to peak ICU need. And, you know, having seen all of the images, videos, and so on, you get a sense of just how dramatic this was. And of course, this raises the concern that if we don't mitigate in any way, how much worse it might get. So then we can ask, okay, if we're going to do social distancing, how long will it last? This is a question that everyone is thinking about. So we thought we would try to use modeling to ask this question as well. And here I'm going to refer to work done by a bunch of colleagues and myself. So Stephen Kissler, Christine Tedijanto, Ed Goldstein, and Mark. And these are reported in a couple of preprints. These are not yet peer-reviewed, but they're going through the process. So one of the first questions that people were interested in, and of course that impact modeling questions as well, is whether there is seasonality. Do we expect there to be changes in how well the virus transmits from winter to summer? It doesn't, if there is seasonality, it doesn't mean necessarily that the virus would go away. It just means it might transmit a little bit less well. And so we wanted to ask, okay, what is the precedent for this? What do we know about other coronaviruses? So here we looked at data from 2 different surveillance systems for the human coronaviruses that have been circulating in North America, and in fact globally, and these are the 2 that are closest most closely related to SARS-CoV-2. And what we see is there does appear to be seasonality, where there's peak transmissibility and transmission in the winter, and then it drops in the summer. It doesn't go down all the way to 0, but it drops. So we can see that there does appear to be seasonality with the other human coronaviruses. And this gives us a basis to then try to estimate what might be going on with this one. So we developed a model for transmission of SARS-CoV-2. And then we wanted to ask, okay, we're implementing social distancing. The distancing can be varyingly effective. And what will the impact of that varying effectiveness of social distancing have depending on the duration of the social distancing? So in these plots, we show in black the epidemic peak as we expect given no intervention. And then we look at what happens with pretty good social distancing, good distancing, and really good social distancing, as represented by reductions in that R naught term that I mentioned. Again, the idea is by diminishing contact among individuals, we will diminish the transmissibility of the virus. The solid lines indicate what we expect in terms of overall prevalence, and the dotted lines, which are offset by about 3 weeks, are the critical cases that we would expect. So the prevalence on this axis and the critical care cases, the critical care cases on this axis. And then we looked at 4 weeks, 8 weeks, 12 weeks, 20 weeks, and indefinite social distancing to get a sense of what would happen. Key points from these modeling efforts that social distancing of any duration results in a lower peak. Again, this is in the context of no seasonality, so we're just assuming in this case there is none. And that long-term, one-time intermediate distancing for 12 or 20 week and then 20 to 40% reductions yields the smallest overall peaks, other than, of course, indefinite distancing. And one of the key points here to make is that as we successfully flatten the curve, we are also keeping people from getting infected, meaning there is a population of people who remain susceptible, so that when we stop social distancing, we will see a second peak, right, as those people are now at risk of getting infected, and we will see, again, the virus return and spread through the susceptible population. What happens if, in fact, there is seasonality? So we're able to use our inferences from the other coronaviruses to just ask what happens with seasonality if it were to be the case for SARS-CoV-2. And what we can see here is that we're aided by the fact that there's less transmissibility in the summer, and so the peaks are a little bit smaller and more spread out. But with our successful social distancing efforts, what we'll then expect to see is an even bigger peak in the fall. And it's bigger because in this case, there's greater transmissibility, again with seasonality, as we enter into fall and winter. And I think this is also particularly concerning because it will overlap with influenza. Now, again, these are looking at social distancing efforts alone, not together with other types of mitigation efforts like contact tracing or the development of new therapeutics, or ideally a vaccine that could change these scenarios dramatically. So this really is just thinking about the contingencies of these types of interventions, social distancing alone. Okay, so one-time social distancing leads to a major resurgence of incidence in the fall and winter due to seasonal forcing. I think this is also particularly important to think about given the importance of events in November, namely the upcoming election, and just thinking about what kinds of measures do we need to have in place as we consider upcoming events. Okay, for a summary of these one-time social distancing efforts, if seasonality is negligible, then all social distancing helps, and long, moderate distancing is best. If there is seasonality, then long, weekly effective social distancing is best, but strongly effective social distancing will actually make it worse by delaying the peak into the winter. So we get, again, more cases because of more transmission, plus it coincides with the flu season. Again, I'm saying this is just in the case of social distancing. If we have other interventions or other efforts, that could change these pictures. And we believe that there will likely be some seasonality. So one-time interventions in the absence of other kinds of interventions could potentially create scenarios in the fall that we really need to prepare for. Okay, if the idea with social distancing is to try to get us below the critical care threshold, right, so that we don't overwhelm our healthcare system, we thought, well, what about multiple rounds of social distancing where we have a kind of thermostat model where we turn on social distancing, where we know that, or we can project that we will be heading towards our critical care capacity, and then we turn it off after our social distancing has brought cases down. This is one way to try to approach this idea of building up enough infections so that we get herd immunity. Again, thinking about how we get to dry land. But in this kind of scenario, given our current critical care capacity, you can see that we'll be doing this for a long time. Prevalence, again, is in black lines, and the critical care cases in red. And again, we have a lag, as I mentioned several slides ago, between these of about 3 weeks. If there is seasonality, then together with very aggressive social distancing, we might have longer breaks, and it keeps peak ICU utilization lower. What about if we double our ICU capacity? So get more ventilators, have more beds available, have more staff. In this case, this allows us to, again, lengthen the time between interventions while accelerating the accumulation of immunity. But again, you can see these are efforts that will take quite some time, even with seasonality. And there would have to be multiple rounds. Something that you can imagine is going to require a political and social will that I have to say I think is unlikely. But this is, formally, as we think of alternatives, this would be one way to do it, again, in the absence of other interventions. So to summarize that section, if there is no seasonality, then approximately 4 to 1 on to off time, slow accumulation of herd immunity. Seasonality can be helpful in this scenario if it really is part of SARS-CoV-2 transmission. Doubling capacity would be a critical piece to this because it allows for longer breaks and faster accumulation of herd immunity. But to do this, not only do we require political and social will, we must have really good surveillance. And that thermostat model would have to be, or the thermostat itself would have to be pretty accurate so that we can avoid overshooting our ICU capacity and really overwhelming our healthcare infrastructure. So I mentioned several times the idea of adding in contact tracing. So very aggressive case finding, contact tracing, quarantine, and isolation. And this was something that we've also looked at. So we can see how the two interact. And the main takeaway from this slide is that contact tracing and quarantine can absolutely be helpful. It depends on how transmissible or how much transmission we're seeing and how many cases we would need to trace, how many contacts, what percentage of contacts we need to trace. And this would require really pretty aggressive efforts, like what we've seen in necessary and continued to be necessary in places like Singapore and South Korea, which has really stretched already very strong public health systems to their limits. And that brings up this scenario, right? This kind of question that's worth thinking through. If we successfully flatten the curve and stand up aggressive case finding, contact tracing, isolation, and quarantine, where are we? Well, in that case, a substantial fraction of the population would remain susceptible. And as I had mentioned, if we stopped interventions, we then expect reintroduction of the virus and the potential for another outbreak. So we would have to maintain at least the case finding, contact tracing, isolation, and quarantine measures going forward. And so that would probably require restricting travel and intensively screening travelers until we get a vaccine and get to that dry land of sufficient population immunity. This is something we're now seeing in South Korea and Singapore and so on, where their travelers who are coming to those countries are bringing with them cases of SARS-CoV-2, and we're seeing little outbreaks of COVID-19 where, again, it continues to tax their already very strong public health infrastructure in order to try to keep cases from taking hold in the populations that are, we expect and believe to be mostly susceptible. Okay, so where are we now, and how are we doing with our social distancing? There are the New York Times has put out some very beautiful figures, which I will share with you here. So first, we are seeing reductions in the amount of travel, but it really varies across the country. And I think this is an important point to make. We're not seeing one single epidemic in the country. We are seeing many local epidemics. And those epidemics are being responded to locally as well. It's a very fragmented response. So there are some counties with stay-at-home orders and some without stay-at-home orders, and we can see the impact on the differences in reductions in travel in this figure. And when we look at this geographically, we can see that it widely varies. There are some places that have been quite aggressive in their social distancing and in staying at home and in trying to flatten the curve and mitigate the peak of the epidemic. But there are other places where that hasn't really happened. So, you know, the different scenarios that I talked about earlier, where we have kind of the solid curve and then the one where it's flattened, we're going to see very different experiences of this epidemic in different places in the country. In Seattle, for example, where it seems as though from reports that we've seen recently, there has been a fair bit of mitigation of spread. There was dramatic social distancing. So from February 28th to March 27th, travel went from an average of 3.8 miles to an average of 61 feet. Right, so very successful social distancing campaign where people are really staying at home. This then suggests if they are, as this suggests, successful, then there will remain a susceptible population. There are groups in Seattle that are trying to get started using apps and other methods, contact tracing, case finding, quarantine and isolation. So we can imagine that that may be the scenario in Seattle or in other places as well. But then again, we have to think about, well, if that's what happens in one part of the country, whereas in another part of the country, we're seeing essentially less successful efforts at mitigation and those populations going through the curve, how will all of us interact in the future, in the next 3 months, in the next 6 months, where there are different pockets with different levels of susceptible populations. And to that end, I also wanted to mention this is, we're seeing socioeconomic differences. This is a figure from today from the New York Times, where we can see that it's easier, as you might imagine, for the wealthier in the population to achieve social distancing and maintain it. And in fact, we might expect that those impoverished populations where they have to continue to work and work takes them into communication with others, and then they come back to their communities, we might expect to see the epidemic hit first and hardest those more impoverished populations, and I believe that's what we're starting to see. Again, suggesting not only the almost the hyper locality of these epidemics, but also the different ways in which they're being experienced by populations. Okay, so this again raises these questions that I think we have to start thinking about. With so much fragmentation across the US, how do we emerge from this? If we're going to have contact tracing in some parts but not in other parts, how does that happen? And I think this is just a reflection of the same kinds of questions that we're going to be asking about the rest of the world. As we think about our own place in it and what travel will look like. What kind of world are we heading back to? I think these are questions, as Deb mentioned at the beginning, we expect things will change as we make choices about how we want to respond and what kind of future we want. And I think that what we're trying to do with these models is lay out possible scenarios. And then I think it's incumbent on us as individuals and as a community to try to anticipate what kind of world do we want to live in, and then how are we going to get there. What do we do now? Well, I think there are some things that are quite clear. We need to build capacity to control transmission by continued social distancing, massive testing, and meeting the needs of healthcare workers for personal protective equipment. And we absolutely need to continue to invest and invest heavily in efforts to mitigate the impact of COVID-19 by rapidly finding treatments, by increasing healthcare capacity, and further accelerating work on a vaccine, as we think again that the ways we can get to dry land are either through infection or through vaccine and sufficient population immunity. So with that, I want to thank folks at the Center for Communicable Disease Dynamics at the Harvard Chan School of Public Health, the COVID-19 team. Mark Lipsich is the lead on this team, as well as all of the colleagues with whom we've been working. And again, here are the references for the preprints that are going through peer review for the work that I talked about here. And with that, I'm happy to turn it over and start to take some questions.
Yonatan, thanks so much. A lot to think about. As you know, there are other proponents who have suggested that draconian measures in isolation, which have occurred in other places in the world, like China, are what is necessary to really get R naught down.
Yes.
In light of your models, how do you think about that?
I think we can certainly see R naught decrease with social mitigation efforts. If we want to get R naught down below 1, so that we can actually see transmission stopping. So again, if R naught is above 1, we'll see continued epidemic spread. If R naught is 1, so that one infectious individual infects on average one other person, you're basically at a steady state. If you're below 1, then we expect on average those transmission chains to die out, so we can actually see an end to the epidemic. It does seem as though from the examples we've seen in China and in Singapore, as well as what we've seen now in northern Italy, that to really be successful, very, very aggressive measures are needed that combine not only the social distancing, but also the case finding, contact tracing, isolation, and quarantine. And it seems like those combinations of efforts were what was necessary to really bring R naught down below 1 and help to excuse me, to control the spread. That said, again, they would be in this scenario where that's in the life raft, that's not at dry land, right? So unless there's a lot more spread that we're unaware of, it would mean in that case that much of the population remains susceptible. And again, you'd have to maintain those efforts of case finding, contact tracing, and so on until a vaccine was available that would enable you to vaccinate enough of the population successfully to prevent spread. So that kind of effort is one where I think you would then have to sustain it for quite some time. With the idea that a vaccine, again, a vaccine is not a certainty. I think that's another point to make. We hope we can arrive at a successful vaccine, but that is not assured. And the timeline we anticipate is, as we've heard repeatedly, somewhere between 12 to 18 months. Perhaps that can be accelerated. Perhaps we can get to a successful vaccine as quickly as possible. That would really be the only way to dry land from that kind of scenario. Again, having that aggressive contact tracing and quarantine and isolation in place would also probably have a fair bit of restriction of travel or intensive screening of travel. As now in Singapore, South Korea, and China, their cases are really coming from travelers entering those countries.
But your models assume herd immunity.
That's the models do not assume herd immunity. That is what we think is what is necessary to lead to dry land, right? That's where things will stop, right? That's what will be the end of the pandemic.
So what do we know about whether that will exist or not?
Yeah, so the hope is that if you either get infected with the virus and then recover, or you have a vaccine that can elicit protective immunity, you can achieve this herd immunity. What remains unclear is whether when you get infected, you get sufficient protection that lasts for at least long enough to lead to the pandemic's end. So when you get infected with SARS-CoV-2 and recover, do you develop protective antibodies? That's really the question. How, and that is as yet unclear. We believe that that is the case. We hope that that is the case, but it's unclear. It's also unclear whether it might, whether the strength of protection and the duration of protection depend on other factors, right? So we know that there are mild cases of COVID-19, or people, in fact, who remain asymptomatic. Do those individuals develop less antibodies, or antibodies that wane more quickly, so that their protection may not be either as long-lasting or as strong? So there are still things there that I think will be important to study and sort out.
Well, then, Yonatan, what's the best way to try to begin to acquire data to better understand that? You know, what is the role of serology, and how should serology be rolled out?
Yeah, so serology is a critical piece to this. So for several reasons. First, there's
Yonatan, can you explain what serology is?
Sure. So in serology, we're basically looking for the presence of antibodies to SARS-CoV-2, right? We're looking to see, have people's immune systems developed responses to the virus. And so we look for antibodies to the virus. We don't expect to find them in people who have not been exposed, and then we do expect to find them in people who have had the virus. So I would say serology is important for several reasons. First, you know, there was a total debacle in the US around testing, and we still don't have sufficient testing. Not having had enough testing from the beginning has meant that we don't really know where we are on the curve in many places. Right? We don't really know how many people have been infected. And as opposed to places like South Korea, where they were doing very extensive testing and could really identify cases and really get a sense of both the severe cases and the asymptomatic cases, you know, and see where they are on the curve, we have lacked those data. Serology of the population can help us understand what fraction has been exposed. And as we do it over time, we can actually see how that exposure is accumulating and get a sense of where on the curve we are. That will be critical to trying to help shape our responses. Another potential role for serology is thinking about, as we move to an end game, there's this notion that positive serology might enable people to get back to work, right? So we may have populations of people who have had the virus who we hope are now immune and then can return to work. So particularly thinking about healthcare workers, those who are at highest risk of acquiring the virus, that kind of data will be quite valuable. There are a couple of cautions with it. When we see antibodies, we don't necessarily know that the antibodies are sufficient for protection, right? We don't know that when we see them, that there are enough of them in that individual to provide protection, and we don't know the dynamics of the acquisition and loss. And also, all tests have some amount of imprecision, right? So the terms we use, specificity and sensitivity. Here, you know, what we most worry about are false positives. So these are test results where it looks like you have antibodies to SARS-CoV-2, but in fact, you don't really, right? So the cross-reactivity potentially with the other coronaviruses raises some concern. Data on responses to other coronaviruses may be helpful in getting a sense of the duration of protection. For SARS, when we looked at the antibody titers, we, meaning the scientific fields generally, not my lab in particular, but when individuals looked at what happened with people who were infected with SARS, how long did those antibodies last? It seemed like it was about 3 years. We don't know what that means in terms of protective responses, but certainly we could see those antibodies going down. For the other coronaviruses, there have been studies where they give the one of the other beta coronaviruses to people, infect them. Again, normally those beta coronaviruses just cause common cold symptoms. And then they challenged them again a year later. And they were able to show that those people, again, got infected with the virus. So for the circulating beta coronaviruses, it seems like the duration of immune protection is actually quite short. We don't know what will happen with SARS-CoV-2 yet, but again, that will be a critical piece.
Why don't we take some questions from other folks? I'll throw in a few more of mine later on. Sharon?
Great. Thanks so much for a wonderful talk, Yonatan. Your seasonality slide where you showed that for the other two coronaviruses seemed to indicate that the two viruses compete with each other. When one peaks, the other one flattens, or vice versa. Can we expect that phenomenon for SARS-CoV-2 in relation to flu or other viral infections?
I don't think we can expect immune competition between the viruses. We do think that there is some type of interaction among the circulating beta coronaviruses. That's right. And picking up on one of the points I just made, people looked at whether antibodies from individuals who had SARS could neutralize the other coronaviruses and vice versa. And it looked like protection against SARS could actually neutralize the other beta coronaviruses, but antibodies against those beta coronaviruses would not neutralize SARS, right? So it may not be reciprocal, it may be a one-way kind of street. So we also explored in some of the models, but I didn't get into it. If you want to look at it in detail, you can go to that, to the manuscript that I referenced, what would happen under scenarios of protection going back and forth in that way. I don't expect there to be much in the way of competition in the immune system ecologically in that sense. There may be interactions among these viruses based on our behavior, right? So I think that as we enact social distancing, not only are we decreasing the transmissibility of COVID-19, the virus SARS-CoV-2, but we're also reducing the opportunities for transmission for influenza and for other respiratory viruses that transmit along similar routes. So there may well be some ecological competition that way through behavior change, or at least ecological impact, if not competition.
Yonatan, even those curves that you showed, there was variability with regards to the peak of the other coronaviruses. Any insights into what impacts the peak of those viruses that would be useful here?
I don't know that I have anything that would suggest whether those peaks have something to do with how transmissible those viruses are, one compared to another, or whether there were other things happening those years, again, behaviorally, that may have influenced those peaks. So it's hard to use that to identify particular factors that might impact COVID-19.
Yonatan, can you comment on the seasonality curves, how they might change in warm weather locations such as Africa?
So clearly, we know that these respiratory diseases circulate in Africa, right? So it is clearly the case that there are coronaviruses like HKU1 and OC43, the two seasonality curves that I showed for the circulating human coronaviruses. Those circulate in not just in temperate regions, but also in tropical regions. The data we showed were really from the US, so it's data for temperate regions. I think an important point to remember here is we're not saying transmissibility or transmission in the summer goes down to 0, it just decreases, right? So if the R naught is, the reproductive number is 3 in the winter, maybe it'll dip down to 2.5 in the summer. It doesn't go down to 0. So we certainly know that there is transmission and transmissibility of these viruses in warm places. Singapore is pretty warm. We're seeing also transmission in Florida, for example. So while there may be, there's the possibility that there is an impact of temperature in reducing transmission, it doesn't mean it's making transmission 0 or in fact reducing it significantly. So I think it's hard to say from these kinds of seasonality data in temperate regions what's happening in tropical regions, but it is certainly the case that we expect these viruses to circulate everywhere.
Mm-hmm. What is the biological explanation for seasonality? Is there something about the virus that makes them less virulent during warmer weathers? Or is it something about the host immune system that fluctuates with temperature?
I don't know of anything to suggest variation in host immune system. I think transmissibility may, because of environmental factors or behavioral factors, may influence this. So for influenza, we know that absolute humidity plays a role in its seasonality. We don't know if that's the case here. And then we also know for flu, there's an impact of school, right? So with school openings and closings, we can see variation in flu as it circulates through kids, and then from kids onto their parents and onto others. So with flu, we have a better understanding of both behavioral and environmental factors that result in the seasonality that has been well studied, but we don't know the extent to which those factors play a role for COVID-19. And this gets to, again, one of the important points that everyone's been thinking about. There are so many different types of social distancing that have been social distancing efforts, from preventing travel to closing schools to closing bars and restaurants. What is the role of kids in transmitting this respiratory virus? To what extent does closing schools have an impact? I think this is something where, in some ways, the very fragmented response and the different timing of responses that we've seen across the country creates many natural experiments for us to try to study the impact of these different interventions. So we can look at when people closed schools, for example, and then look at what happened in that interval, both to the amount of social distancing that we saw through using the kind of mobility data that the New York Times so beautifully represented in its figures, and as well looking at impact on the amount of disease in a population, which is really the factor we're interested in.
Yonatan, you've probably seen there's now an uptick in cases in places like Hong Kong and Singapore. So I'm going to put you on the spot and ask you to try to project or imagine how we're going to come out of this. Right? How are we going to stop social distancing? How are we going to try to approach a new normal?
Yeah, I think this is, those were the different scenarios that I was highlighting. And I think that there are tough choices, and each option is difficult. So in places like Hong Kong and Singapore, they are seeing more cases from importation. And that, again, is we expect, unless there has been a lot more transmission in these places than has been reported and that we're aware of, they continue to have a large fraction of their population susceptible, which means introductions will again lead to more spread. So they are forced to continue to invest heavily and maintain very aggressive case finding, contact tracing, isolation, and quarantine in order to prevent further outbreaks. And this is again why I was saying that we're basically in the life raft, and dry land is getting population immunity, whether through a vaccine or through infection, and that this time period we're looking ahead to, will be, choices about how we want to do that. How do we want to approach that, approach dry land? And these are the various options that we have in front of us. Either, try to slowly control, or to enact these kinds of aggressive measures while we wait for a vaccine. And it's not easy in any option. I think that it's going to be hard whatever way we choose. And then choosing how we want to do it is going to be critical. Thinking about the fact that there are so many different local responses, I think, is also going to be one of the hardest parts to this, is how do we integrate as a community, as a country, when we're seeing very different experiences, and we'll probably see very different choices on how we get to dry land from community to community. So what does that look like in 3 months or in 6 months? I think those are things that we will certainly need to grapple with.
But Yonatan, what your current models don't factor in is the fact that there are, and there are going to continue to be, increasing numbers of deaths because of COVID-19, but not from COVID-19.
Yes.
Right. And so the complexities of the models need to increase dramatically to take in these other factors, including other diseases and deaths from other diseases, the economic impact. How do you integrate all of that in?
Yeah, so these models are intended to be comprehensive models that ask what's going to happen to the economy or what's going to happen with other diseases. Here, we're really just asking, with this pandemic, and then other things. I think those factors that you were describing come out of that. So, for example, emergency room visits, outpatient appointments, all of those have plummeted in the context of this pandemic, as no one really wants to go to hospitals and risk getting exposed to and becoming sick with COVID-19, right? So if someone has chest pain and worries about a heart attack, is that person now going to be more likely to stay at home, and we'll expect to see worse outcomes? Or as the hospitals are overwhelmed with, and the infrastructure, our healthcare infrastructure, is shaken by dealing with all of this, will we see increasing deaths from other causes? I think that is almost certainly the case. Here, we're not trying to anticipate what those additional factors are, but absolutely, as we make our choices about what route to take, we'll have to consider the fallout, the impact across a wide range of sectors.
Yonatan, as you know, it would be important to know if the elderly, who are typically less protected by vaccines, will be protected, as they are at the highest risk of having severe complications. There's now also concern that immune modulating therapies such as IL-6 inhibitors may impact immune response. How do you think this may play into your models?
We are in this case, we have not stratified the population by age group. We're just trying to take a very simple approach, because as we were building these models, I think we haven't really had the data to get a sense of how differently our age populations responding. So, do kids respond differently than middle-aged, respond differently than the elderly? We know that there seem to be, now we're getting more and more data about lower rates of asymptomatic disease in kids. What happens in terms of immunity? I think those types of questions are still pending. And we're starting to see people who are building age-structured models where we can use information about from China and from other places, now that we're starting to collect it, as to what fraction of the population by age was infected and the outcomes in these different populations. So once we are able to incorporate those kinds of data, we could ask more tailored questions like this one and ask about particular age groups and what might happen. In our model, again, we're just dealing with the simplest scenarios, in part because we don't yet have the data to really rigorously parameterize and build those models. As those data come in, I absolutely think that I totally agree that being able to do more nuanced, age-based understanding of both what has happened and then trying to use that to predict what will happen will be quite valuable. And again, those data are rolling in. This continues to be something we're learning about in real time. It's the whole idea of building the airplane while flying it. Right? We're trying to adapt as quickly as the data, as reliable data are available.
And going back to your models of expanding ICU capacity, could you explain the assumptions behind the impact of expanding ICU capacity? If, absent effective therapy, the mortality for patients who end up intubated is roughly 50%, how does increased ICU capacity substantially blunt mortality in models with frequent oscillations of incidence?
Yeah, so with those, we were really thinking about not just, so it's, I think the idea is that as we're starting to see, we've heard about from Italy, and we're starting to hear concerns about in New York City, the availability of ventilators will become limiting. And so we would expect to see the mortality in those who require ventilators go up, right? So if we don't have the ability to ventilate people, we'd expect to see an even higher mortality rate. So the notion of increasing our ICU capacity is that it would enable care for more of those patients and lead to a kind of stabilization of the mortality rate. Whereas if we exceed that capacity, we will see a higher mortality rate. Right? So if not everyone who needs a ventilator can get one, that will certainly increase our mortality rate. So that was really the thinking there. And the notion in the intermittent distancing model was that by increasing our ICU capacity, that will give us a little bit more breathing room, so to speak, for if we were to try to do something like pumping the brakes with social distancing and turn it on and off to try to minimize the extent of excess mortality from those who needed ventilators and wouldn't have access to them.
Yonatan, what about the fact that the most vulnerable are the elderly, but the younger population seems to actually get very mild disease? What about unleashing them to develop herd immunity? Let them go and socialize.
Yeah, so there have been ideas about cooping up people above a certain age and waiting this out until we get a vaccine, or kind of trying to get enough of the population to get herd immunity. But I think that makes I think there are ethical problems with that. If you say as soon as you turn 60 or 65 or 70, you can no longer engage with the rest of the population. I mean, the vision of what that kind of society looks like, I think is quite problematic. And it isn't as though we're talking about that herd immunity would necessarily stop transmission in those populations. Who would care for people in retirement communities? Who would care for people in nursing homes? Where would those individuals come from? It sets up this really bifurcated society where as soon as you turn into whatever age we're setting as a cutoff, you go off into these communities and can't interact anymore. I mean, the concept of that to me is quite troubling.
Yes, but I would play devil's advocate, right? That if you could couple it with rapid testing, that you could actually, rapidly assess what population of people that it is safe to interact with. That you can imagine a kind of.
I think that's certainly something that people think of as we start to have serological, in the sense of as we have serological tests and can start to think about reintegrating people into society or opening up the economy. That those with antibodies are going to be the protective antibodies are going to be the people who can do it. But again, I think that there are uncertainties about how you actually put something like that into practice. I think it's not clear at an kind of an institutional level, right? So do you say that we're going to screen everyone, and those people who have been negative to date are not allowed to come into the building? Only those people who are positive can come in and work. What does that? How do you set that up economically? How do you set that up institutionally? And more broadly, how do we think about that as a community where in some places there will remain highly susceptible populations because they've successfully flattened the curve, whereas in other populations, if the epidemic has swept through, they have now kind of experienced the epidemic and are through to the other end, to dry land, through having population immunity. As we have some areas of the country with very different experiences. How do we integrate as a community overall? I don't think these are easy. There are any easy answers to this. And I think if you try to work through the logistics of how that will happen, it's quite challenging.
But you're arguing for a federal mandate then with regards to lockdown.
Well, I think what we certainly have had delinquent at best federal leadership in this, and I think we need to start to anticipate what will happen across the country, and then have ideas for what our country should look like in 3 months and in 6 months, given the variety of different possible scenarios. If we continue to have very, very fragmented responses, we may be in different places. Some places may be on dry land, some places may still be in the lifeboat. How do we reintegrate? I think those are questions that, yes, whether at the federal level or whatever, we need to start thinking about what a vision of a future looks like. What kind of place do we want to live in? And then we have to ask ourselves, what can we do, both as individuals and then as constituencies for governments at all levels.
So I apologize, we can't answer every question that has been pouring in, but I'm going to let Sharon ask one last one of Yonatan.
Yonatan, given how important a vaccine will be in achieving herd immunity, can you comment on your sense for how well the vaccine development effort is being coordinated, either on a national or international level?
I wish I could, but I don't have great insight into that. I hope it's being that many people are. I know many people are working hard on developing vaccines, but I can't speak to the extent of coordination or the different stages for various vaccines, other than what I suspect everyone else has been able to read more broadly.
And
Sharon, you want to have one follow-up?
Sure. So the last question is, we're getting a lot of questions about social distancing. What do you think is the most effective right now for people in Massachusetts and in Boston, in our community?
I think staying at home and trying to minimize the amount of kind of the stricter measures are really what we need right now, as we try to understand which are the most effective levels of social distancing. We still don't know, right? We don't really have a playbook for this. So being most aggressive and trying to minimize interactions with others to the extent possible seems physical distancing, right? You can still have Zoom and so on, but minimizing that level of physical proximity and the opportunity for transmission really seems like what we need to do now. While at the same time, we can, again, as I mentioned before, use the fact that there have been so many different types of interventions and done at such different times relative to the epidemic. You try to gather the information from these natural experiments to be able to more appropriately tailor the interventions that are most successful to the communities where they would benefit from them. And then similarly, as we think about lifting the social distancing interventions, do we do that all at once, or do we do it in a staged way? Do we do it in a staged way, community by community? They're having the information on which types of efforts were successful, and also having all of the testing data, both virologic testing and serologic testing, so we can really know where communities are on their curves will be necessary to do this in a kind of data-driven and reasonable way.
Yonatan, in a single letter, give Boston a grade for social distancing in the mild, moderate, severe categories of your modeling. Single grade.
I will refrain from doing that, and I haven't seen all of the data for Boston or for Massachusetts generally, so it's hard for me to say. I think one thing I will say is that, you know, it takes a few weeks to see the impact of social distancing, right? So, and this is one of the things that I think a lot of people have a hard time conceptualizing. You're so used to seeing what's in front of you. In this case, we can use the examples of Northern Italy and New York City as examples of what's in front of us, right? What happens now determines what will happen in a few weeks. This social distancing that we're successful with now pays its dividends in a few weeks, right? So even if you might not see the cases, you might not know of people around you who are sick, you know, it's the efforts now that will help prevent the peak in, or help flatten the curve in a few weeks. And I think that's an important point to keep in mind.
Thank you, Yonatan, so much for your time, and thanks everybody for joining.